Okay, welcome everyone. We're going to go ahead and get started. I'm very excited for today's talk. Today we will be hosting Dr. Meredith Rosenthal from the Harvard T.H. Chan School of Public Health at Harvard University. Dr. Rosenthal is a professor of health economics and policy and the Associate Dean for Diversity at the Harvard School of Public Health. And I just want to talk a little bit about her role as the Associate Dean. She provides extraordinary leadership in strengthening diversity and inclusion, community engagement, and cultivating student and researcher engagement. And I just want to say on a personal note that Dr. Rosenthal is a supreme kind of mentor, and I want to thank you for all of your time that you gave me while I was there as a postdoc. Dr. Rosenthal's research focuses primarily on policies that will help slow the growth in healthcare spending. Now we're going to hear a little bit more about that today. Dr. Rosenthal, being an exemplary figure in her work, was recently inducted or elected to the National Academy of Medicine. Her work has been published in the New England Journal of Medicine, the Journal of the American Medical Association, Health Affairs, and numerous other peer-reviewed journals. And during the 2008 presidential campaign, Dr. Rosenthal provided analyses to Barack Obama's healthcare team regarding opportunities for Medicare payment reform, pay for performance, and cost control. So today, Dr. Rosenthal will be discussing the factors that affect the use of non-recommended services among the commercially insured. And I just found out that she has strong ties here to Penn State. Both her grandparents were Penn State alum. So let's welcome her home. So let's give a warm welcome to Dr. Rosenthal.
Thank you. It's really lovely to be here with you today. I'm going to try to stay a little bit in the camera, although chances of that are not that good. Great to join you here today on this somewhat murky March afternoon. And this is a topic that is one that I've been interested in a long time, and the Choosing Wisely campaign, when it began almost 5 years ago now, just was a great opportunity to get into this kind of work. So please, just as a ground rules, please interrupt, jump in at any point. I certainly don't want to talk at you for this entire period. One of the things that's always interested me about overuse is that it seems like it's one of those phenomena in healthcare that is determined by so many different factors, and there is this, it's very hard to get clinicians to talk about overuse in general, which is one of the reasons I was so interested in Choosing Wisely. And in particular, I think in part, it's very hard to separate what is being driven by financial incentives versus what is driven by clinical norms in the overuse of healthcare services. And I think that it's my belief, at least, that those two things have become inseparable. Physicians, they are not often directly aware of the financial incentives to do X or Y, but they're sort of baked into the system, and norms develop in ways that are consistent with financial incentives, but it's not entirely clear that if we introduce policies to change financial incentives, we'd see commensurate changes in practice. And I think the other thing that I've been interested in, the work that I've done over the years on physician payment in particular, is this idea that, as we move towards payment reform that de-emphasizes fee-for-service and uses population models of payment like capitation, global budget, there's always a concern about the underuse of necessary care. But you hear much less concern about the notion of overuse under fee-for-service and the hazards of overuse. And it's my suspicion from working in health services research for the last 20 years that, in fact, the hazards of overuse under a fee-for-service system are much more severe than the hazards of underuse under a globally paid system, because of sort of all of the clinical training that really reinforces the idea that physicians should A, intervene, and B, sort of keep the sort of patient health as the first concern, that clinicians are really trained to think about conflict of interest only in the setting of withholding and not of over-delivering. So that's a bit of a simplification, but it's something I'm really interested in teasing out ultimately through some more qualitative insights. So you can tell from the first slide that my collaborators are all listed at the end of the presentation, but you can tell that Bruce's worked with Dartmouth because of the map. So I actually don't know what that's a map of. That is not a map of overuse. As you'll see, the map of overuse looks like every other map of voting rights, but you name it, where the north and the south are very different, and the coasts and the middle are very different. Of course, the first challenge of doing work around overuse is defining what we mean by overuse. As an economist, of course, I think about overuse as anything where the marginal benefit is less than the marginal cost, and generally in a societal perspective, but we can think about that at an individual level as well. Choosing wisely takes a somewhat different approach to overuse. Not surprisingly, the notion of choosing wisely really was about a sort of a soft launch in engaging clinicians and professional societies in particular in the discussion about overuse. And the softest way to get to overuse really is to look at those services with zero marginal benefit or such disproportionate cost to benefits. And so choosing wisely is really sort of starting by focusing professional societies on identifying those services where there is very little benefit. And then in fact, in most cases, physicians and patients could, in a fully informed way, agree that these services should not be done in these specific instances. So, this is a way of looking at overuse that looks at perhaps the least controversial kinds of services where there are alternatives that deliver better benefit to cost ratios. The other thing about the framing of choosing wisely that's really important is that this is a discussion tool. When we first started talking to the American Board of Internal Medicine and the Thayer Foundation, which launched this with leadership from Chris Castle, who's now at the National Quality Forum, we said, well, we want to take your measures and look at data. And they said, wait, these are not measures. These are recommendations, and they're recommendations that are intended to be used in the context of a discussion between an individual doctor and an individual patient. And so one of the interesting things to watch the Choosing Wisely program over the last number of years is that tension play out between sort of this goal of engaging physicians in a non-threatening way and the fact that the delivery system is actually looking for tools to directly affect overuse at a population level. There's a bit of a tension there. And in fact, for the most part, payers have stayed away from implementing policies that directly use choosing wisely. ABIM has sort of discouraged the use of these recommendations for things like pay for performance or public reporting, and there really has not been that much take-up of that. Most of the activity around choosing wisely has been either at the health system level or the society level, the community level, but payers have really stayed away from using these recommendations directly. One of the things that is sort of interesting is that there have been some consumer engagement initiatives, not the subject of what I'm going to talk about today, but Consumer Reports has partnered with the American Board of Internal Medicine Foundation to develop consumer-friendly materials. And some of the Aligning Forces for Quality communities that Dennis and others have worked with over the years have adopted community-based initiatives using Consumer Reports materials and other community-based engagement efforts. So that's sort of been the flavor of this work. Nonetheless, of course, as health services researchers and health policy researchers, we're interested in understanding to what extent do these measures, do these recommendations matter? Is it possible to translate them into measures? And what will we find out about the variation in overuse according to these recommendations at a population level? And we're doing this work both in the Medicare population and in the commercially insured world. Others have started looking at Medicaid overuse. So for the first piece of the work that I'm going to show you today, we started with a set of the recommendations that were relevant to the Medicare population. It looked initially in the Medicare population and then mapped those, a common set of those that could be mapped into the commercially insured population. Some of the recommendations are age-specific. And population-specific. So, for example, there are recommendations that have to do with the care for individuals on feeding tubes, the care for individuals at the end of life. Obviously, those don't translate very well into the commercially insured population. We wanted to look at the recommendations that we thought would most likely to be prevalent, the denominators, that these kinds of situations arise frequently. We were interested in measures that we thought would capture resource use, significant resource use. There are some of the societies made recommendations that had essentially no measurable resource use implications. So the orthopedic surgeons had some, none of the orthopedic surgeons' recommendations had to do with surgery. They had to do with certain processes in the context of orthopedic surgery, those that have zero impact on anything billable. They of course do use some resources and then health implications. One of the papers that we did early on was just to map out all the recommendations and look what it was that these professional societies recommended. And so initially the sort of early adopters of this Choosing Wisely initiative were the primary care societies, and then in the first year I think there were 10 societies that came out with their own list. Most of the recommendations had to do with imaging. Something like 2/3 of all of the recommendations had to do with imaging, even those by the radiologists. And so you can imagine, when it comes to imaging in many fields, the professional society that's recommending less imaging is not financially impacted at all by that recommendation. So, if primary care physicians stopped ordering as much imaging for knee pain or back pain, it would have zero effect on their bottom line. It's somebody else that actually profits from that. So it's very interesting to look at the nuances of what is actually recommended. So we tried to focus on those where we thought there would be the biggest impact, essentially, on healthcare. And I can say more about the specific recommendations. Every society took the challenge in a very different way, and many of them essentially, had a real balance between tackling important sources of waste and making recommendations that maybe were not exactly in the spirit of Choosing Wisely. One that I pointed out in some of our earlier work is the Emergency Department Physician Society. On their list was don't delay palliative care for patients who arrive in the emergency department with a serious life-limiting condition. Really important recommendation for healthcare overall, not exactly an overuse. Really, that was an underuse recast as an overuse. Don't delay. Most of these things are no-do. And so then we looked at, in our first paper using Medicare data, included, again, a fair amount of imaging and testing. Don't do imaging for low back pain. Don't order cardiac tests on low-risk asymptomatic patients. Most of the services listed in that top group were actually recommended by multiple professional societies as probably overdone, probably should only be done in a very small number of cases. I think one of the things that you might notice from this list is none of these are super controversial. Like some of the services listed in the Choosing Wisely list 5 years ago had already been identified in society guidelines a decade before, 2 decades before, as potentially inappropriate, potentially overused. And some of these also are listed as USPTF D recommendations, so some of the services that the U.S. Preventative Task Force has long suggested should not be done. And yet, of course, we see relatively that payers continue to pay for them. These continue to happen. Before we got into this, we didn't have a good sense of the prevalence of many of these services. I think back pain is probably an exception. There has been a fair amount of work over the last decade and a half. John, I don't know if you've been involved in any of that, that has looked at the frequency of imaging for back pain. So the other thing that you might notice about these recommendations is they contain words like low risk or high risk, and they don't contain CPT or ICD-9 codes. Yeah, John?
I guess what I'm wondering about is why, if there's universal recognition that these things aren't worth the cost, maybe have almost no benefit, why are the payers still paying?
Yeah, it's both.
Presumably this is exactly the ammo they would need to not pay and not get too much pushback from it. The doctors themselves and the professional societies are saying, hey, we don't even think we can do this.
Yeah.
It seems like a get out of jail free card for payers.
Well, you know, it's interesting. So again, as I was saying, the way Choosing Wisely was framed is very much not that these are on-off switches, that we think that these domains describe situations in which the services are almost always inappropriate, but they're defined in such a way that there's always an out. And the ABIM Foundation really strongly came out against health plans using them for coverage determination specifically, and the plans so far have not gone that direction. Not a longer and interesting story, as you know, in the public sphere, the idea of rationing from any central-based decision rules is, fairly controversial. You all remember death panels not very long ago. And so even though it seems like, again, these have been, many of them USPTFD recommendations, now the societies have listed these for everyone to see on the web. Can't we stop paying for them? I think that there's a pretty big chasm between where we are and that outcome. Commercial payers, likewise. Commercial payers, as it turns out, have relatively little incentive to really push cost control. Most of them make all of their money on ASO fees, and so they're more concerned about their relationships with doctors and employers, and so rationing is kind of unpopular with both. Yeah, Dennis?
I have a related question, but I guess really getting into the politics. I've often wondered, the same thing. My understanding is that many professional societies they came up with something so that they would be included, but
yes,
they really didn't approach this with any kind of strong desire to sort of push the envelope. I mean, politically, in terms of who, was there any, as you look back on this, any traction on this, either through ABIM or those who provided funding by ABIM to actually try to push a little harder? And I'm kind of curious about the politics. Was there significant pushback when they tried to do that, or did they just not try to do that? Because, sort of per John's question, I mean, this had the potential, at least, to be a little bit of a game changer. In my sense, it really hasn't become that. So.
Well, I think it has neither. So, from what I know, not having been there or studied in depth the politics, but having had a few meals with Chris Castle where she was willing to share a little bit more, she basically went to a bunch of societies after there was an initial paper that was the primary care societies, I think in 2000, I lose track of time, 2010, 2011, where they had these lists, just the primary care societies, and she went to a broader set of professional societies and said, we want you to follow suit and come up with these lists of 5 services that should not be done. And most of them said no. But she got a few societies to come forward, and that put pressure on the others to come forward too. And again, I think it's a very interesting analysis. Now there are more than 100 lists, I think. If you look across them, the 1 or 2 I can think of, like interventional cardiology, I think there were a couple societies that went at their bread and butter, and said we shouldn't be doing this thing that we make most of our revenue off of in this group of people, and they seem to have taken it really seriously. And others, and again, I think including the orthopedic surgeons, you look at that and think, okay, really, you want credit for that? So it's very, very different, and it's not clear what the external pressures are here. It seemed like there was enough external pressure that most societies I have never heard of. I had no idea how subspecialized medicine was in the U.S. until I started reading these lists, like, I don't know, pulmonology of the left lung. I mean, it's really, there are a lot of these little groups, so they clearly felt some pressure, but there was a very strong framing of this about being professional, all in the professional domain, not about regulation, payment, and that these recommendations were intended only to influence doctor-patient conversations. And so I think you're right. I don't think that they have had a big effect. I have certainly reviewed papers over the last couple of years looking for a global effect. And I'm not very surprised that there doesn't seem to be one, that we don't see dramatic changes in these practice patterns. But again, I think there's a little bit of devil in the details too, because like most guidelines and evidence-based care recommendations, there's always there's this gray area of, when it may be appropriate for certain patients. I think that's not true for every recommendation. Some of them are clearer than others. And one of the, so this DEXA measure that don't do it more often than 2 years is like one of the clearer recommendations, because it's just about the predictive power of the test makes it so that you don't gain any information if you do it more than every 2 years. There's not sort of an extenuating circumstance, but for most of these things, there are extenuating circumstances where there's family history, for example, which you obviously can't tell in claims data, where there are risk factors that don't exist in claims data as well. There's always a certain amount of uncertainty, and I think that makes it harder to use these for high-powered incentives or coverage decisions. So we'll see. It's generally been my belief that if these recommendations were going to be effective, they would be effective because a health system, maybe an ACO, that would have the legitimacy to figure out a localized decision rule based on their recommendation, that's where it would happen, that if Blue Cross or Highmark or whoever started saying we're not going to pay for these, that there would be a fair amount of outcry.
It's not that beating dead horse, but at least when I deal with my insurance companies, Highmark, which is a Blue Cross affiliate, I mean, it seems like they've got contingent coverage rules for all kinds of things. So they recognize that there are scenarios where the general sort of applies. But they're used to setting up these things. My girlfriend has a mammogram and it's suspicious, and then they move to a digital mammogram, and if that's suspicious, they move to an ultrasound, and just haven't been through this. It seems like they're well versed. They have
sort of fail first kinds of rules or step coverage.
Like zero marginal benefit, except for the handful of people. It just seems like they're already well positioned to kind of build that into coverage. So they're already doing it for lots of things, I guess, if I'm saying.
Yeah, no, I think that's a good question, John. And, when you think about where there are good step therapy rules right now in private insurance coverage, they're around very high cost, either technologies or drugs. And a lot of these things are not high cost at the outset. A lot of these things, one of the things I'm interested in looking at next is, a lot of these things lead to other costs. They are themselves relatively low cost. Vitamin D deficiency screening, it's ridiculously overpriced, but it's not like as a percentage of your total premium. You wouldn't even notice it at the third decimal place. And so I think, some of these things are in that category, whereas, when we think about the things that aren't on the list, like back surgery when it's unnecessary, knee surgery when it's unnecessary, those are the things that have managed to stay off the list. those seem like the ones that you might use coverage to affect. And then, I think in the example that you gave too, that it may be that there is a logical sequence, and then a step therapy kind of coverage model makes sense. These things may not lend themselves to that. So, but I'm very interested to look at, for example, one of the things, actually, I don't think I showed this results. When we look at overuse of cardiac testing, the most overused cardiac test is an EKG, which is very inexpensive. But if you do an EKG on everyone, then a certain number of those people have false positives, true positives, sort of not clinically significant, but something comes up where then the physician needs to refer you to the cardiologist, and then the cardiologist has to do an angiogram, and then while she's in there, she might as well put a stent in there. And so that there's kind of a snowball effect. So I'm interested to what extent that happens here. But it may also be that the kinds of things that have made the list so far are pretty low cost. And so for the coverage hassle, they're just not worth it. So these spill over onto, so the last one here, don't use opioid or butalbital treatment for migraine except as a last resort. I think that one is increasingly of interest given the opioid epidemic. Other recommendations that we measured that we could look at both in the Medicare population and in the HCCI population. HCCI is a national-ish commercial health insurance database. We have claims from Aetna, United, and Humana around the country, so they're not everywhere in the same prevalence as the population, but gives us a national picture of a kind. And so you can see that the rates of overuse vary quite widely, and without getting into the technical details, in part because I'm not the clinical expert on this project, for each of these measures, decisions had to be made about how to essentially carve out the high-risk versus low-risk patients. We did so in the most conservative manner. For things like back pain imaging, there are lots of published studies, some of which use claims-based measures that have been validated on clinical data. So we followed the literature to the extent that there was one. And in other cases, we took the most conservative approach. So my guess is that these are low relative to a stringent version of overuse. Although again, I think where your definition lies could certainly vary between reasonable people. And so you can see that the levels of overuse between Medicare and HCCI are relatively similar across services, not totally consistent. Vitamin D screening appears much more frequent in the Medicare population. So again, non-indicated vitamin D screening, and the range is in terms of in hospital referral regions to look at geographic variation. That was sort of this first paper is looking at how widely the variation, how wide is the variation and to what extent is it map between Medicare and HCCI. And not surprisingly, it looks like a lot of this variation is characterized by a market and looks very similar within that market between Medicare and commercial payers. And as usual, we have some markets where the measured overuse is quite low, and some where it's really, really high. And the correlation overall between Medicare and commercial is very high. And these are the last couple of measures: DEXA testing and preoperative cardiac testing. And I think for me the testing measures, like the DEXA testing and vitamin D testing measures, I think they're very interesting because they often set off, for Medicare population in particular, they set off a cycle of annual or biannual testing. So it's not just this one test, it's once you have a test, then they call you back to have a test every 2 years on DEXA scanning in particular. Patients then have DEXA scanning, and my understanding from looking at some of our results, again not shown here, we have electronic medical record data from a large health system in Massachusetts where we've been looking at, when we look at DEXA scanning, most physicians record osteopenia as the indication for DEXA scanning for the ones where we have measured it as non-indicated, which means that basically someone had a DEXA scan, it looks like they had some bone loss, so that becomes the indication for continuing to do the service, and so we have this sort of perpetual testing scenario without obvious clinical benefit.
So it's an interesting one. We're kind of starting a new project, and I'm just learning about this bone density DEXA scan, so I'm not by any stretch an expert, but we're talking with some folks that are. And my understanding is that this measure is sort of second one within 2 years.
Right.
Like that.
Yeah.
My understanding is DEXA screening is significantly underutilized. It's USPTF recommendation in primarily the female population with certain age range. And so this is one where actually, according to the orthopedic folks that I've been talking to, it's really underutilized in the population.
Yeah, so in the Medicare population, we only look at the frequency because it's indicated for the over 65. In the under 65, and I don't know if I have the results here, maybe we'll come across them. In the under 65, we also look at the overuse. So if you're under 65, there are certain risk factors that suggest that you should get scanned, and both. There were two measures on the Choosing Wisely list. There's the frequency measure, which again, whether you think 10% is a lot or a little hard to say. I think it's all part of certain people, and we can see regionally that there's this annual visit which Medicare is to pay for, and people just sort of get all their tests. And there's some people who are just on the annual visit. While you're here, let's do the DEXA scan. And how much concern you should have about that, I guess it depends again what the sequelae are, whether patients then get treatment either pharmacologically or by other means, and whether that is indicated or not, I don't know. But that's a good point. I think, again, one of the things that I find really interesting about overuse is that overuse and underuse kind of go hand in hand, and in general, you'll see that in those areas that do better with all the evidence-based measures of care that we want people to get, they also do worse on Choosing Wisely. So people get more care, they get more care. And so I think that's an interesting policy riddle, is to try to, how do we address the overuse without having unintended consequences on recommended care? Yeah.
How much does perceived potential litigation play into some of this, particularly in the preoperative cardiac?
Yeah.
I would think that the physician's office is clinicians to get run an EKG and everybody just to make sure.
Right, I guess that's
any potential litigation.
I think it's very hard to tease out what is litigation related. We don't try to do that at all. Others who have looked at litigation related testing find a significant but relatively small effect. And that's using identification based on either changes in state malpractice rules, or using state-by-state variation. And so there's almost surely some of that here, and I think it's interesting to think about how that might be different, as you were suggesting, across different measures. So maybe that's where we'll see it most, is in the preoperative testing. But the other thing, to the extent that the preoperative cardiac testing is done in the inpatient context, it's not, that those tests are being reimbursed separately for the most part, certainly not in Medicare, but for the most part on the commercial side. So, you might need a story that isn't about financial incentive so much as either litigation concerns or clinical practice. But, again, if those tests are low value and they have consequences in terms of, as any test has a risk, but I think for something like an EKG, I think the risk is a clinically, a result that appears to be significant that's not clinically significant, and then triggers certain other kinds of high-risk interventions. It reminds me, though, I like all of you, perhaps, when I do this work, I think about my experiences as a caregiver for my family, which get more and more interesting as the years pass. And my parents are in their 80s, and my aunts and uncles, too. My uncle was supposed to get surgery for bladder cancer, and he was very anxious about it, went in for the preoperative test and basically failed his EKG, and they had to delay the surgery until they could figure that out, which turned out to be nothing. So I think these things, they're very complicated, and I imagine that litigation is one among many concerns.
It's interesting.
Yeah.
It seems like the subset of these that are actually, that have been de-recommended by the task force, it seems like that would take a lot of heat off in terms of the potential for litigation.
Yeah.
I mean, I wouldn't, if I was a trial.
And it's a de-recommended.
I mean, it seems like it'd be hard to sue a doctor for doing something that a national task force told him not to do.
Well, so I know probably much less about this than you do. But I used to sit near people who did this kind of work, and Michelle Morrow's office was right next to mine for a while. So my understanding is that the standards, the precedents under malpractice have changed over time in terms of whether there are local norms or national norms that could be applied to these situations. Some of you probably know more than I do about this. So my sense is that there is an evolving standard in terms of to what extent can you appeal to something like the USPTF or choosing rising recommendations or other national standards like that in your defense in terms of malpractice. So I wonder if that's true. You would, again, I can't remember where it was, but this is sort of post-ACA. Mark Fendrick, who many of you probably know, has done all this work on value-based benefit design. He was, looking at the waiver of co-payments under the ACA for recommended preventive care, and was asking why there wasn't a symmetry in terms of co-payments for de-recommended services. That it does seem like the most obvious place to go is something that's been de-recommended. At the same time, when the most recent mammography guidelines recommendations came out of the USPTF, enormous controversy over those recommendations, and the sense of trust in a government agency from a political perspective, I think, is it keeps everyone away from doing what seems like it would be common sense. So we took these measures and created a composite score so that we could look at some regional variation across the measures. And in fact, as you saw, perhaps it wasn't in the previous slide, the measures themselves are quite highly correlated within the region. And as I was saying in the beginning, the map that you get when you look at overuse across this set of recommendations looks like a lot of maps you've seen with the darker areas, in this case the higher rates of overuse in the South, in Florida, Texas, but also I think they're interesting up in my hometown where you walk into the emergency department and you instantly need a brain MRI. Lots of these other places with high cost patterns. So basically the map that we look at for overuse looks very similar to total per capita cost in terms of healthcare spending as well. And so this is aggregating data from 2006 to 2011. And one of the other things I would note is looking across these measures, there's almost no trend. That the level of overuse has been quite consistent over this very a period in which healthcare spending has generally grown relatively slowly, but overuse itself has maintained a pretty flat trend.
Yeah. Interpret that into composite.
The the composite is, I mean, it's a z-score, so it's basically your, how many standard deviations you are away from the mean you are. The higher composite is at the upper end of the distribution.
And the mean is national mean?
National mean, yeah. This is the same map, but using the HCCI data. It's a little bit more blotchy in the south. It's a little bit more filled in the south there than the Medicare, and picks up a little bit more in the west. But again, pretty highly correlated with the Medicare map. Interestingly, Massachusetts looks a little bit better on the commercial side, although I would say that the national insurers have relatively small market share in Massachusetts. So, so overall, what we find again, what we expected to find, that there is this strong area level component to patterns of overuse, and that those patterns are pretty consistent with what we know about that story around high costs in terms of both in terms of utilization, right? So when you think about the story around McAllen versus Miami, that utilization-based cost drivers, these overuse is part and parcel of that. Even though, what we think drives overuse around in Medicare tends to be about post-acute care, but perhaps, the same impetus to do the test that leads to the intervention, that leads to the hospitalization, that leads to the post-acute care, these things are all tied up in one package.
Your results are also interesting for that mean debate about McAllen versus El Paso or whatever it was. There was an article that came out later that showed that the initial finding was driven by the fact that they used Medicare claims, and they redid the analysis using private insurance claims, and there were still some differences, but I think it's 75% or something.
Yeah.
It's interesting, those correlations you put up, you don't find that. You find that the overuse is just as prevalent in private insurance.
Yeah, the study that you were talking about was done using HCCI data and released last year. The marketing of those findings I found sort of interesting, the findings, I don't know, by the authors, by the publisher, by HCCI, were marketed as showing that the original ones didn't make sense. I think that what the story was one that Mike Chernew published many years ago, is that the big story for commercial insurance is price. Which is not to say that there's no association in terms of the utilization pattern, but of course these populations, they're quite different in terms of their need for interventions and certainly for post-acute care, which is such an important part of the Medicare story. So they're really different. I read the way the press picked that up as that, this was showing that the earlier findings were correct. They were absolutely correct for the Medicare population. Commercial is different because there's not an all-payer pricing schedule, and the price differences are so enormous that can, is a much bigger determinant of variation.
Yeah, my reaction wasn't that the Medicare analysis was wrong, it's just that there might be pretty pronounced differences across private. You couldn't extrapolate the Medicare experience to everything else.
Right.
What's interesting about yours is that there's correlation.
They're very correlated.
And the means are quite similar, in terms of magnitude.
Yeah.
I mean, this is just, it's not a mini story, but it's kind of an interesting aside.
Yeah. Well, the reason we looked at it is because we did have this sense from talking to physicians in particular that there are these practice norms, especially where there's a gray area around the evidence. So, when a patient is in remission after the acute phase of cancer treatment, how often should they go to the oncologist? How many times a year do they get imaging, blood testing, etc.? These are things for which there aren't strong guidelines in many areas. And we're told by doctors is that, we just develop a strong culture. When you get trained in a particular academic center, the idea is that you should see, your most serious heart failure patients 4 times a year. at a different place, it's twice a year. And it doesn't really matter whether those heart failure patients are commercially insured or Medicare, that, we thought that these practice patterns will be determined by these local norms, and that does seem to be in part the case. It may be that, when you look at, in the aggregate at differences between commercial and Medicare utilization, it's just the spectrum of utilization for Medicare is so much broader, and there are many things that just aren't relevant to the commercial population. We're specifically looking at those services where clinically there was a big enough denominator for both Medicare and commercial, and so we're looking at a particular spectrum. Yeah, please.
Related to John's question, so especially appropriate using and using video as much on the clinical side, but do you think that these exceptions might be more common, I guess, on the Medicare side? Is that?
I think that's probably true. You mean so if we're just those words high risk or family history, once you get to be 65, there's a lot more of that. Yeah, for sure.
Maybe it's almost further interesting. You almost think that Medicare side could have more.
I think there are two countervailing forces. One is there's more complexity, and again, once you get to be 65, your family history is different than when you were 25. Your parents have aged and encountered all those things that they're going to encounter, and so that suggests that there'll be more of this sort of reason for these services. On the other hand, there's also, we know, if you go to the doctor, you get more stuff, and if you're over 65, you go for more sort of routine care, you expose yourself to greater potential for overuse. While you're here, we'll do this test and that test. So I think that those two things are happening at the same time, and maybe, they neutralize one another to some extent. But I think you're absolutely right. You have many more risk factors as you get to be older.
You try to replicate this analysis in the Medicaid population?
No, but I know some folks that are doing that.
And what do you expect from that?
So I can tell you what I expect. I can't remember what I've seen them present. So I would expect, again, there's sort of countervailing forces. Medicaid is a terrible payer. So on the supply side, I'm much less likely to want to supply these things to you because the reimbursement may be just incrementally above my costs. On the other hand, I would guess that that Medicaid populations might be in a very different sort of shared decision-making position with their physicians, given cultural norms and I think that when you look at the quality of care in Medicaid populations, we see pretty significant differences, lower quality of care on the underuse measures, and so that may translate into even more sort of beneficial reductions in overuse. But yeah, so I think it would be kind of a mix. The one thing I was going to say, so we did look at area level measures of sociodemographics. You can see here what we were able to include before things blew up has included race, ethnicity, rural, and poverty measures. And the one that's significant is those areas with higher Black population have higher overuse. And while we have area level fixed effects, in part I think that's still picking up these regional differences. So not totally clear. Poverty does show up negative in the commercially insured population. So again, that's not the individual level measure of poverty, but it's an area level measure of poverty that seems to reduce overuse, which again can be consistent either with people with lower income are less likely to go to the doctor. You don't go to the doctor, you don't get unnecessary services, or there may be payer mix issues that lead to less overuse. So overall, in the area level analysis, not surprisingly, we found that higher spending areas have higher level of overuse. Again, it seems very consistent with what we know from Medicare, but it also shows up in the HCCI composite. So that's going to John's point again here, sort of overuse in the commercially insured population looks quite similar in terms of patterns as it does in the Medicare population. Physician group concentration is very small and hard to interpret there. We have to get a negative sign in Medicare, a positive sign in the HCCI, so that's areas with basically a higher Herfindahl for physician groups have lower overuse in Medicare, higher in HCCI, so that it might be consistent. Oh, sorry, that's negative. I'm sorry. So not totally clear there why that would go in that direction. Specialist to primary care ratio. This we expected that areas with greater numbers of specialists have higher overuse, and then the higher quality score, which is basically a composite of HEDIS measures of things like recommended mammography, sort of cancer screening, all of that, but that's positively associated with overuse. And so again, the tension of how do we think about a policy tool here that would not have an unintended effect of reducing these HEDIS-like measures while reducing overuse.
What's the area? Is it county or HRR?
Well, you had to ask. I think this analysis is all done at the HRR level. Mm-hmm.
But Medicare data could look at the racial effect individual.
Yes, and we did. So that analysis is underway, and a fellow has been working on it, so I haven't seen the latest results, but we're using the individual data for Medicare to do that.
It's only county data, perhaps use more overviews, and in the different study I looked at, just looking at screening overviews for age 85 versus screening as that. Maybe not significant, but probably still usually know, less like
to get screened.
Yeah.
And so it helps them when it comes to not recommended services. Right. I know that's been shown in other racial differences, inequities, although in this case I think over-prescribing of antipsychotics that's less likely in Black populations too, so it seems to be there's sort of a single continuum, and it's good in some senses and bad in others. Yeah. So in the HCCI data, one of the reasons we got the HCCI data was to allow us to look at benefit design factors. So we do a patient-level analysis using HCCI alone and examine the effective differences in benefit design. I don't have, has anybody worked with the HCCI data? It's tricky. And it's a little tricky, and was very, well, I have my gratitude slide at the end. We're grateful that they sold us the data for $50,000, but although probably I was, according to my contract, I wasn't allowed to say that. But it was really challenging to get the data. It took like a year and a half, and they have these rules to protect privacy that go well beyond what Medicare. It was much easier to get Medicaid data, Medicare data than it was to get HCCI data, and so like if you wanted discharge dates, or if you wanted something like 3-digit zip code, you couldn't get other things. So it was a constant Rubik's Cube of trying to figure out what limited data set we could actually get. So we don't have as much granularity on benefit design as I would like. So essentially what we're able to do here is characterize high deductible plans versus all others, and HMO products versus all others. Those are two separate things, and there are actually these days high deductible HMOs. So all 4 cells are filled. Go figure. And so, the main question is that when I go and talk to clinicians about overuse, in many cases they'll say, well, yeah, I know that the patient didn't need an antibiotic for sinusitis, But she came to me and she was threatening to go to another PCP, and our relationship was really dependent on my writing that script. I can imagine that in some cases, but I also feel like in all of these doctor visits with my parents that I'm having now, I spend all of my time trying to talk them out of things. And so I just wondered what the real story was. And this is a very beginning piece of trying to separate out how much is patient-driven, how much is doctor-driven, and where should we intervene if we're going to intervene to try to reduce some of these services. Yeah, John?
That's a spark my memory. I remember seeing a paper in Abstract just the last week or two, and somebody was decomposing medical spending and trying to figure out how much it was patient versus provider.
Yeah. Is that Amy Finkelstein? I think Amy's working on something on that, yeah.
And I actually found, I'm probably wrong, but it was something like 50% was patient.
Yeah.
It was a pretty large number. Kind of more than most people would have thought.
Yeah. It would be interesting. I trust that Amy knows what she's doing. But I haven't looked at it in detail, but I knew that there was something there.
What I wonder about in your context specifically is, whether or not some of this overuse is, it's not clinically beneficial, but it's beneficial to the patient in terms of providing them extra assurance or something like that. How to think about that. So it sounds like your personal experiences on exactly counter. You wonder about patients, that say, well, it's probably nothing on your mammogram.
Right.
If you go to the digital, we can say for sure. And then I guess you have to start thinking about willingness to pay for that extra certainty. Because maybe on average it's not clinically indicated. Mm-hmm. But people are risk averse. I just wonder how all that factors in thinking about it.
I think that's absolutely the right way to think about it, John. But so, when I started and said there's a definition of overuse, you think about like a bunch of economists in a room who have never been to the doctor would say, okay, well, we should look at the marginal social cost versus the marginal social benefit. And we're utilitarians, we just care about the average. And so that's like the most draconian in some ways ideas of overuse. But then you can say, okay, well, how about the marginal benefit to this individual patient given their preferences versus the marginal cost to that patient? That would give you another kind of overuse, and there'd be fewer things that meet that definition than the first one. And then you can get to choosing wisely, though, which is like, actually, when we sit around, we really think that you may feel better, but it's only because you've been misinformed about the benefits of that test. And so choosing wisely is like not even going to the fact that we have variation both in underlying risks, but also in preferences. It's really saying, actually, the risks associated with this test exceed the benefits in any sort of reasonable clinical sense. And, so preferences still come in there, but I think that these things are pretty far from that frontier in terms of, where preferences should matter.
A risk-averse person would actually be disinclined towards these things under full information.
Under full information. I'm not saying that every one of these will follow that, but the way Choosing Wisely was designed, it was meant to stay away from, from even sort of talking about through the classic choices that people make around interventions, or I think there's something other than watchful waiting, something that sounds better, but intervention versus watchful waiting for prostate cancer, those kinds of decisions where we know they're highly preference driven. These services generally are where clinicians think that there's almost no benefit and there are no risks. And they're not even thinking about dollars. So I think you're right in principle. This is intended to be sort of the lowest of the low-hanging fruit. But ultimately, we wanted this piece of the research to help us begin to think more about what might be the levers for reducing overuse. And when you look in Medicare, of course, you see all this regional variation, and we know that the price differences across those regions are pretty modest, that most of that variation is not being driven by Medicare payment per se, which is not to say that payment changes might not have an effect. And as some of you may have seen, the other group at Harvard that's been working on Choosing Wisely looked at the effect of Pioneer ACOs, which are sort of the most the most aggressive version of the ACO model with real prepayment, and they actually found that the Pioneer ACOs reduced these overuse measures by a significant, statistically significant, but relatively small amount. So that's where we want to go with this. I'm not going to claim that we're there yet. So again, these are on the HCCI data, the non-overweight population, and we used some of the same measures that I showed you before, some different ones, and we're looking at a logistic regression here with fixed effects for HRRs, with the limited patient characteristics that we could get from the HCCI data. So these are the measures that we do the analysis on. And just so you know, the cardiac testing measures, there's actually a few recommendations in there that are all bunched together because the recommendations are separate for EKGs, for angiograms, et cetera. And likewise, preoperative cardiac tests, we aggregate them. And short interval DEXA measure here is overuse in people under 65 without a specific risk factor for DEXA scanning. So this is a group that should not have a DEXA scan at all, so it's not the frequency measure. This is just our patient population. Pretty good age distribution across the lifespan up to Medicare. These patients are mostly very, very healthy. And we have about, you can see that I did the population measure here with a separate denominator, so every measure has a different denominator, and the people in the denominators are a little bit different because the people in an HMO are a little bit different than the non-HMO. So about 10% of the population in HMOs, just opioids and migraine, you'll see that that group tends to be the younger folks, so more younger folks in HMO plans. High deductible plans are about 15 to 17% across these cohorts. So here are the results of the analysis. The gender patterns in terms of overuse vary by measure. Women are less likely to get some of these screening tests. More likely to get, these are odds ratios, more likely to get vitamin D screening and opioids and migraine. And then you can see that the older cohort is, the left-out cohort, the 55 to 64, is at a higher risk of overuse for almost all of these measures except for opioids and migraine, which I think is interesting. Health status also, generally, patients with more comorbidities are more likely to get the non-indicated services, which we take to sort of that's, in this relatively healthy population, if you have a chronic condition that brings you to the doctor every year, twice a year, you're more likely to expose yourself to some of these services. Yeah, Joel?
So with the 55, 64 on Medicare,
yeah.
Is it that physicians are using age as some sort of, you're almost using that as just a risk factor?
Certainly. It could also be that we're just picking up unmeasured risk factors. So then these are claims data. We can't see everything. We can't see family history. The older you get, the more family history you accumulate. So maybe that is just telling us we have a measurement problem. And that's in part why we've gone into the electronic medical record work to try to understand how much those things vary. And I don't have those results for you today, but it looks very different across different measures. For low back pain in particular, we find that if you have all the medical record data, that many of the people we said were non-indicated actually were indicated. They had long-term chronic back pain. It wasn't the first episode, but you can't tell that in these data. So I think it might be a mix of those two things. And I think the use of opioids in migraine, the recommendation, this is one of the ones where the recommendation is a little open-ended. It's sort of like, don't use them unless you've, failed clinically on these other kinds of medications, and it's not totally clear what the threshold for that is, and given concerns about addiction around opioids, I really wonder whether the recommendation could be or would be stronger these days, and we see the overuse rates pretty substantial there, I think given the risks associated with opioids. Although we had a really interesting presentation this spring in the department where someone came and presented some work on opioids, looking in the workers' comp population and how some of the state laws that have been enacted to try to restrict opioid use really were having measurable effects both on self-reported pain and on work loss days. So their withdrawal from the workers' comp population is having significant negative effects, and at the same time, given concerns about addiction, an interesting, murky health economics problem, public health problem.
So just clarification, the health status.
Yeah.
Is that formal status?
It is. So it's basically a count of comorbidities. Yeah. So the more means you have more comorbid conditions. And then, so this is, the part that we were kind of interested in. The ASO results, that's sort of the only other indicator of health plan type that HCCI would give us. I don't entirely know what to make of. What to think about ASO plans. These are obviously self-insured plans, and the results don't help me on that point. So it's there for completeness. I was mostly interested in the high deductible health plan results. Because I wondered, if consumers are driving some of this, would the high deductible really act in a way to limit patients' both sort of willingness to seek care, but also their willingness to accept high-cost tests or potentially low-value tests? And I think the answer is maybe. So it's really it varies across measures in a way that I have not been able to establish, an overarching logic. You could imagine there could be a different logic, for example, for the pre-op cardiac tests, where there's the financial incentive, depending on where you get it, could be little or none, especially if you're getting a big operation, you're going to meet your deductible anyhow. But there, it seems like having a high deductible health plan actually makes you more likely to get the test. And then, again, opioids and migraine, your drug benefit may not be under the deductible, so I could have seen that one not being affected at all. But there, having a high deductible health plan means you're less likely to get opioids and migraine. So I haven't made sense of these results. Except, obviously with a big data set, we see significant effects, but I wonder if they're picking up things about the selection. People aren't randomized to these plans, so there's selection into the plans, but it's not even consistent across the measures. So
you can do the probably. We can try when they actually get these results. These are
in terms of where they are in
terms of the benefit.
Yeah.
I tend to use all deductible service ones I I do. I wrote it, okay, I need it, doctor, okay, what do I need? Screening, and I think it's really, I'm responding to it. So, either it's based on interact with the health status, or secret, it's very likely you need to doctor already.
Yeah, that's interesting, Jeff, because also it could be that these services are different in terms of, where they might fall in that, so we could potentially look over time to see whether we can track out the sort of effective cost sharing. So, at the end of the year, are you more likely? Some of these, again, like the opioids and migraine, those are chronic, right? So you would, they're not supposed to be, but people use them chronically, and so that might be less likely to be affected in that way, whereas the low back pain, getting the MRI, the possibility of surgery, people might be more likely to take that step after they've met the deductible or when they think they're close to their deductible. So that's a good idea. I think we could do that in these data, even with their limitations. Yeah. And limitations, there are many. We were selective about what services we looked at. The services that we're looking at make up a very small percentage of total cost. And even as far as we can tell, sort of using your eyeball, looking at all the Choosing Wisely recommendations, no one's going for the big game. So there are no Buffalo on those lists. So there's, even if you added them all together, I imagine you'd come to less than 5% of spending. They were, in effect, designed to be an opening foray and not too high risk. Most societies took this as an opportunity to show that they were willing to participate, not to really put it all on the table. And so we're looking at small game here. If we could move towards the higher cost testing and the interventions, you might find very different patterns there. It reminds me a little bit of Tom Sequist, who's one of my co-authors, has done some work in Atrius Health, this big physician group in Boston, where they looked at showing doctors the tests, the cost of their tests at the point of ordering in the electronic medical record, and he found that showing them what tests caused a decrease in low-cost services, but no effect on high-cost services. And so your sort of willingness to give up overuse in the low-cost stuff may be greater, maybe because these things feel like they're lower consequence. But when you're actually thinking about, well, should we do the extra imaging for the patient with headache because of concerns about liability or just concerns about risk in general, clinical risk, that those things are harder to get clinicians to really talk about potentially consequential services like that. And of course, we wanted administrative data and all this, and even though administrative data are really the best place to measure utilization, it's really hard to measure utilization in electronic medical record data. So they're ideal for that. They're not good for capturing risk factors or patient history, patient family history in particular. But that challenge is exacerbated by the nature of the recommendations. The recommendations themselves are fairly imprecise. So they allow for very sort of patient and provider specific concerns to enter. I think the word concerns is actually used there. How are you going to measure that? So I think if you had perfect clinical data, you can't measure sort of all of those things. It can't easily be translated. And our commercial data are specific to United, Humana, and Aetna, and they're not evenly distributed. And as yet, there is no perfect commercial insurance data that's national. I think the state all-payer claims data sets give us really good data for an individual state, but so far, no move to have that happen on the national front. So, this work we've been doing for about 4 years now. Really, our initial ambitions were relatively modest, which is to ask whether it was possible to identify some of these Choosing Wisely scenarios in claims data. And when we looked in the electronic medical record to do a better job of getting at things like medical history and other kinds of concerns that weren't well targeted by the claims data, we find that it's variable. Claims data can give us a pretty good idea of overuse in some areas and not great in others. So the opioid measure looks pretty good. The low back pain measure looks pretty bad. We did find, however, that there are already very strong regional patterns where the commercial insured population, Medicare population have very similar patterns of overuse. And that suggests to us that there is some local norms and sort of structural differences across markets, within markets, that is contributing to some of this variation. And in terms of our efforts to try to figure out patient factors, in particular looking at benefit design and plan design, that has raised more questions than answers. And it's not altogether clear whether intervening at the benefit design level is going to be the most effective way to address overuse. So, comments, questions?
What was the conclusion removed?
What was the name that did you make that? I think it was another Medicare one. This just seems like beating a dead horse. Yeah, it was another Medicare one.
Yeah, let me take a shot at that. This conclusion, Jeff.
That's number 4.
Yes.
You do find there's a high degree of correlation between quality of healthcare in the area and overuse of that area. If somebody come back to you and say, that may be a physician fixed effect. But people who are actually very good at providing quality services at the same time tend to use services, sub-services in a way which would be measured as overuse. So that's also significantly undercuts the policy argument for choosing wisely recommendations in constraining the overuse, especially if you're measuring quality. I mean, if you're measuring quality by those very same measures, it's very difficult to understand why there's a strong correlation. If you're measuring quality by somewhat different measures than some of these recommendations, then it is a significant problem.
It's a problem. I don't think it's conclusive. I do think it should cause us to step back. So, you know, what it suggests to me is that a blunt instrument is going to have unintended adverse effects on those HEDIS measures. So the quality measures that are in that quality index, again, are things like, you know, flu shots, mammograms, pap smears, a lot of preventive care, but also recommended chronic disease management. And I think probably what causes them to be correlated is basically access. It could be a physician-fixed effect, but I think it's access. Patients have better access. You have better access, you're more likely to go for a visit, and you get all the stuff you're supposed to get, and then you get a bunch of other things thrown in. And the question is, do we have policy instruments that are nuanced enough to not prevent people from getting their mammogram, but to make sure that they don't get the DEXA scan every year? And I'm not sure that we do, and especially in Medicare, these sort of centralized. So, you know, I think about policy interventions like waiving co-payments for screening. That sort of, you know, that's as nuanced as Medicare policy has gotten recently, as, you know, waiving co-payments for recommended preventive care. But likely some of that has also caused some overuse. So I am really concerned about the linkage, whether it's at the physician level, the health system level, or just says something about access to ambulatory care. I'm worried that we don't tend to intervene in ways that is refined enough to get at the overuse without harming the underuse problem. Yeah, Dennis.
It seems like a good area to study interventions in. I'm generally familiar, I know as you mentioned, a couple of BA4Q communities that have had some grants and things, but I forget specifically what they did, and there are a couple of others as well. Maybe the question is, are you familiar with any good interventional work, either, you know, so for example, Linda's here from our benefits office, I often wonder if we widely circulate some of these things within our employee population, could that make a difference? Or you know, you could imagine intervening with willing providers or whatever the case would be. So I'm wondering if you've seen anything that you would consider a potentially powerful intervention, and if you know of anyone that actually studied this.
Yeah, I was just at a behavioral economics conference at the end of the last term, and Jeff Colvin was there from the Michigan VA, and they had done an intervention where they used, and I'm going to describe this poorly, but physician commitments, like physicians committed to considering the choosing wisely recommendations in some particular area. So somehow they got the physicians basically to adopt them in spirit, and they found significant changes in overuse. I think it was around things like, you know, that you get routinely as a primary care physician, like sinusitis, and so that was one. So no financial incentives. It was really just it was leveraging this idea of a commitment. You know, and the other interventions that I know of, and part I've been involved in other related price transparency interventions, again, which is making sure the doctors know how much it costs to do X and are aware of the Choosing Wisely recommendations. Those have not been effective. I don't know of other interventions, but I think that other people are working on this for sure. The ABIM Foundation tries to keep tabs on all the related research, so if you were interested in following up with them, I think that that they would have more information. I think it's really interesting. As I started, I really like overuse because I think it's so messy and controversial and challenging. And there has been a lot of interest in getting into this, but I think there's still a lot of hesitation about using a really high-powered intervention because of the concerns that something bad will happen, because a lot of these things are sort of the test that could, change a clinical pathway. And even though when you look at the underlying studies behind many of these recommendations, not all of them have evidence, by the way, but when there is evidence, the evidence suggests that the costs in terms of adverse effects of the testing itself are significant. I think it's still very controversial to use high-powered incentives, and so it's not too surprising that we haven't seen much changing. Personally, I think sharing these recommendations with the community is really important, but not sufficient to get behavior change.
The question about your maps, I find them very interesting. And did you attempt to kind of look into different large provider networks and the use of?
Yes, that's a great question. We're doing that now in the next phase of the project. We have ACO survey data that we're mapping to the Medicare data, and so we'll be able to look at self-identified ACOs, what they say they're doing in terms of, are they aware of Choosing Wisely, have they created interventions around it, how they pay their doctors, what kind of quality improvement efforts do they have, so all of that. So that's a way, both at sort of both the variation that we see across these ACOs, but what kinds of internal mechanisms might they have in place to try to address this?
Pennsylvania was perfect because you can almost see the major provider networks outlined. You know what I mean? Like the geographic region, there's like 3 or 4 major provider networks, and the Southwest region was in red, and
UPMC?
It was kind of interesting. It was almost.
Yeah, right, and Boston's all right too. Yeah, okay, shall we?
Yeah, I think we shall. Let's all take
Thanks, everyone.
Nice to see you. We don't understand. Oh, well. I'm not working on it.